Hello, everybody, and welcome to the InTouch Health webinar series. This is Scott Young, and I'll be your host for this webinar. Today, we'll be featuring Jordana Bernard and Rochelle Clark of InTouch Health, and they'll be presenting on Telestroke billing in 2019. Jordana Bernard has 20-plus years of progressive leadership in the telemedicine industry. Jordana currently serves as the Director of Policy and Public Affairs at InTouch Health. In this role, Jordana executes strategies for key telehealth advocacy and policy initiatives. Prior to joining InTouch Health, Jordana served as Chief Program Officer for the American Telemedicine Association, overseeing strategic objectives to advance the telehealth industry in education, accreditation, practice guidelines development, and alliances with professional societies, governmental agencies, payers, and industry. Jordana received a BS in Biomedical Engineering from Boston University and an MBA from Marymount University. Rochelle Clark serves as Senior Clinical Quality Director for InTouch Health. Shelley is an RN and Certified Professional in Healthcare Quality, achieving her Bachelor of Science in Nursing from SUNY Upstate Medical University in Syracuse. Clinically, she practiced in critical care, emergency, and neuroscience nursing. She has served in numerous healthcare administrative roles, including both as stroke coordinator and neuroscience administrator in local hospitals and vice president of Reach Health Clinical Services. In her current position as Senior Clinical Quality Director for InTouch Health, she is responsible for establishing the quality management program for physician services and providing consultation to optimize telemedicine network performance and align clinical outcome priorities with both quality and revenue cycle opportunities. Our webinar will begin shortly, but first, a few notices. At the bottom of your audience console are multiple application widgets you may use. If you have any technical difficulty, please click on the Help widget with a question mark icon to cover common technical issues. You can expand the slide area by clicking on the Maximize icon on the top right of the slide area or by dragging the bottom right corner of the slide area. During the webinar, you'll be available to ask questions in the Q&A widget located on your audience console. Questions will be asked at the conclusion of the presentation, so please feel free to ask them at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be shared within the first 48 hours, and this webinar presentation should last about 60 minutes, including the Q&A time. And now I'd like to turn it over to our presenters, Jordana and Shelley.
Great. Thanks so much, Scott, and welcome, everyone. Thanks for joining us today. I'm going to start us off with a legislative and regulatory update highlighting federal policy changes that impact payment for telehealth and Telestroke specifically. I'm also going to talk about different Telestroke scenarios and the billing opportunities that will be available in 2019. And then Shelley Clark will cover the steps involved in developing a Telestroke billing process, including a discussion around key coding and documentation topics. So let's get started by setting the stage. And from a high level, let's first look at how reimbursement works for telehealth among the different payers. At the federal level, we're talking about Medicare coverage. And these rules for reimbursement are outlined in Section 1834M of the Social Security Act, which was enacted about 20 years ago. First, the law says the Medicare patient must be located in a federally designated rural area, which essentially restricts payment to a very small population. Second, it limits the settings or originating sites where the Medicare patient must be located when receiving care, and this is to certain types of medical facilities. There are 8 types that are approved. It also specifies which types of healthcare providers are allowed to provide services, and it requires the services to be delivered using real-time interactive video with just a couple of exceptions for federal demonstration projects in Hawaii and Alaska. Lastly, Medicare only reimburses for a specific set of approved services. This list of approved services gets updated annually by CMS, and in 2018, the list went up by 7 codes, and for 2019, CMS added 2 more codes. So now we have a total of 98 codes as we move into the new year. The law also allows Medicare to pay a facility fee to the originating site. At the state level, the picture is a little bit brighter because states have the ability to set their own rules for how telehealth is treated. And over the last few years, we've been seeing state Medicaid programs being more progressive and trending towards offering more reimbursement opportunities for telehealth and eliminating unnecessary restrictions to make their policies more telehealth friendly. There's a range in how states are reimbursing, and it goes from a Medicare program in a state like New Jersey, which only reimburses for telepsychiatry services, to a state like California that reimburses for live video across a wide variety of medical specialties in various settings. Then on the commercial side, we're also seeing payers trending toward offering broader coverage for telehealth services, although how much and which telehealth services they pay for can vary, again, by state. States also create their own reimbursement rules for the commercial payers, which often involve parity in coverage of services, though not necessarily in reimbursement. Today, the majority of states do have a parity law that's in place. So this is how telehealth reimbursement has worked over the years, and as you can see, it's been very constrained now for about 2 decades. But let's fast forward to 2018, and what we saw this year were major breakthroughs in the policy landscape. On the legislative front, during the current 115th Congress, which comes to a close this December 31st, we saw lawmakers introduce bill after bill trying to expand access to telehealth services by chipping away at those constraints that have been in place around using telehealth by Section 1834M. And the first big policy win ever for telehealth occurred this year when Congress passed the Bipartisan Budget Act of 2018. This groundbreaking piece of legislation has 4 components for telehealth, 2 of which are in fee-for-service and 2 are in value-based care. The first provision addresses Telestroke, and remember, historically, reimbursement for Telestroke services has been severely limited because of the requirement that the hospital where the patient is receiving services, which is the originating site, has to be in a rural area. Well, with passage of the Bipartisan Budget Act, the rural restriction will be removed, and this will then allow payment for every stroke patient in every hospital across the nation. The law also added the ability for a mobile stroke unit to serve as an eligible originating site. The second provision also removes the rural requirement for patients with end-stage renal disease who are receiving home dialysis therapy, and it will allow providers to bill for clinical assessments by telehealth into hospitals, standalone dialysis centers, and even into the patient's home, regardless of geography. Both the Telestroke and the end-stage renal disease payment policies go into effect on January 1st of 2019, and the impact for these 2 use cases is really going to be large in terms of, finally getting payment in place that can clearly make an immediate impact on both patients and providers. This new payment will allow programs to initiate these services as well as to allow those who have been delivering these services without getting paid by Medicare to finally be able to bill. Also included in the Bipartisan Budget Act were 2 provisions that increase flexibility and the incentives to use telehealth under Medicare Advantage plans and in accountable care organizations. And these 2 provisions go into effect January 1st of 2020. Currently, CMS is collecting public comments on the proposed rules for the Medicare Advantage provision. So we expect the final rules to come out next spring. And although fee-for-service is still the primary structure for reimbursement today, as evidenced by the legislation and the regulatory actions being taken, we're seeing both Congress and CMS pushing the healthcare industry towards using more and more telehealth in these capitated and value-based payment models, because they're recognizing that telehealth not only improves care delivery, but it can do it in a more convenient and cost-effective manner. Along with the passage of the BBA this year, we also saw passage of two other major pieces of legislation with policy wins for telehealth. These were the VETS Act, which implemented the VA's Anywhere to Anywhere telehealth program. This went into effect in June. And the Support for Patients and Communities Act, which passed in October, and it had two provisions for telehealth. The first provision similarly removes the rural geographic requirement for eligible originating sites, and it adds the home for the treatment of substance use disorders and co-occurring mental health disorders. This provision goes into effect July 1st of next year, and the other provision puts a deadline of next October on the DEA to finally get the special registration set up for telehealth providers. And this is also very important because it will make it a lot easier to prescribe controlled substances without being required to have an initial in-person visit with the patient. On the regulatory front, CMS released its final rules for payment under the 2019 physician fee schedule on November 1st. And wow, the payment policies outlined for telehealth in this schedule represent a major shift for CMS in terms of their attitude towards telehealth. One of the most significant policy changes in the schedule was around CMS's decision to introduce payment for new types of virtual care services and remote patient monitoring. Clearly, CMS understands the constraints around payment and reimbursement, and they found a way to work around them by calling these services something other than quote-unquote telehealth. And by doing this, these new services and RPM will not be subject to the rural requirement or the other 1834M limitations placed on traditional Medicare telehealth services. These three new virtual care categories include a brief communication technology-based service, which is basically a real-time synchronous interaction by telephone or video to see if an in-person office visit can be avoided. The second new category is a remote evaluation of recorded video and/or images, and this is essentially a store and forward visit where a patient sends in an image or a video clip to be evaluated by their provider. And both of these new services are not limited, again, to geography, but they're also not limited to specific application or specialty area or even to setting. So the codes can be used very broadly. And then the third new category establishes payment codes for interprofessional or provider-to-provider consultations that can be conducted in real time using the telephone or video or asynchronously through the internet or the EHR. There were also big changes to be aware of with regard to remote patient monitoring. Here, CMS finalized three new payment codes, which will augment existing CPT code 99091, and the new codes will enable separate payment for the full range of professional services and the technical components associated with remote patient monitoring. CMS also included policies for the Bipartisan Budget Act that implement payment for Telestroke services for purposes of the diagnosis, evaluation, or treatment of symptoms of an acute stroke. Very importantly, the rules remove the rural requirement for hospitals and mobile stroke units serving as originating sites, which again will allow virtual physicians to finally be able to bill the professional fee regardless of the geographic location of the patient. With regard to the originating site facility fee, unfortunately, there are a few constraints to be aware of. First, CMS will continue to pay the facility fee, but only to hospitals and critical access hospitals that are in rural areas. And unfortunately, the law does not allow CMS to pay the facility fee when the mobile stroke unit serves as the originating site. In the schedule, CMS also finalized the definition for a mobile stroke unit as a mobile unit that furnishes services to diagnose, evaluate, and/or treat symptoms of an acute stroke. This broad definition allows the full range of mobile units to be able to serve as originating sites for telestroke consults. That is, from the typical ambulance augmented with telehealth to a mobile unit outfitted with a CT scanner and capability of delivering TPA. So now let's walk through a number of different clinical scenarios that you may be considering for telestroke and talk about the potential billing opportunities for both the professional fee and the originating site facility fee. First, when telestroke services are delivered to a patient in a hospital setting, there are payment codes for an initial consultation to an ED or inpatient setting. And in this scenario, the distant site provider could bill the G codes, that is the G0508 for critical care or G0425 through 427. For an inpatient subsequent or follow-up consultation, there are other codes that could be billed. This would include G0509 for critical care and G0406 through 08. For an inpatient subsequent consultation, that is when a patient is no longer critically ill, the professional would bill CPT codes 99231 through 33, but it's important to remember that these codes can only be billed once every 3 days. And then in the scenario when a telestroke consult is provided to a remote site and the patient is transferred to the distant site and admitted, the critical care G0508 through 09 codes or the G0425 through 27 codes could be used. However, if the same physician provides the virtual consult and admits, the in-person codes are used to bill from the distant site. Next, for post-acute services delivered to a patient in a nursing facility, a subsequent consultation would be billed using CPT codes 99307 through 310. However, in these circumstances, billing is limited to one telehealth visit every 30 days. And lastly, for a post-acute telestroke consultation in an outpatient setting, the professional fees could be billed using CPT codes 99201 to 215. For all of these scenarios, when the originating site is in a rural area, the medical facility would be able to bill the originating site facility fee, and they would use HCPCS code Q3014. And the originating site facility fee will be about $26 for each patient visit. Here's an overview presented in numerical order of the most commonly used payment codes for telestroke and their associated payment rates for 2019. These are the national averages for facility RVUs. Shelley will go into more detail about the use of these codes, but I would encourage you to refer to guidance provided in the physician fee schedule and the 2019 CPT manual and other guidance that we do anticipate coming out from CMS in the early part of the year, and just around, making sure that billing appropriately using the codes. Additionally, as you prepare to bill for telestroke in 2019, you'll continue to use the place of service 02 for claims for telestroke professional services. And starting in 2019, though, Medicare will require the use of a new modifier for telestroke payment codes. This modifier is only to be used for telestroke claims, and the new modifier is G0, G-O or G0. And this will need to be appended to the professional and originating site facility fee billing codes. Lastly, it's important to be aware of a provision in the Social Security Act that states a Medicare provider must submit a claim for any Medicare-covered service provided to a Medicare patient. In other words, when the Medicare conditions for payment are met, the Medicare mandatory claims submission rule applies, and providers are actually required to bill for these services. When billing Medicaid and other commercial payers, the rules for billing telestroke may be different from the rules we've discussed here for Medicare. For example, two commonly used codes for the delivery of in-person critical care services to stroke patients are CPT codes 99291 and 99292. However, these codes are not included in the list of Medicare-approved codes. So it's important to contact your other payers, the ones that you work with, to learn about their specific rules for payment, including which billing codes and modifiers you will be required to use when submitting claims for Telestroke services. So in summary, in 2019, we will have significantly better payment for telehealth, and in particular for Telestroke. And so this is the time to get familiar with these new rules, get your billing processes in place so that you'll be ready to take advantage of the revenue opportunities and this new paradigm for reimbursement in the new year. Well, that's it for me. I'll turn it over to Shelley now, who will dive further into the processes around how to implement Telestroke billing. Shelley?
Thank you, Jordana, and hello, everyone. So I guess my first question, is your head spinning? Because we know ours is, and understanding all of the new rules and regulations is quite challenging. InTouch Neurology, our physician services department, provides acute teleneurology consults to ED and inpatients who require immediate neurological consultation to prevent further morbidity. The majority of our consultations are Telestroke, but we do have a fair number where we may be called for an acute seizure patient. So as we began looking at the Telestroke billing planning process, we were overwhelmed with the information. We also realized that we needed to target where we wanted to start it. In order to do that, rather than throwing darts at a dartboard, we decided to put together a formal billing planning process. We used the familiar PDSA tool. Many of you may have a different template that you use. But what we're going to cover today is the 5 steps that we took to begin our plan. We have not implemented yet, but I'm hoping that by us sharing with you our process, it will give you some suggestions that you can use to embark on the process as well. The focus of today will be on billing for that professional fee. So the first step was to assess our external environment. And of course, the very first step was to review the Medicare guidelines for Telestroke billing, which Jordana just did so eloquently. So I won't be repeating that, but I will make a recommendation that you take these slides, which will be provided to you at the end, and you review the information from Jordana's presentation, and you actually highlight the sections that apply to you so that you can focus your efforts. When we began this process, we realized that there may be a phase 1, a phase 2, and a phase 3. So you may decide to do the same. Then the second thing we did was we consulted with compliance. The role of compliance is to make sure everyone involved in the billing process is educated on applicable laws and regulations. And this is new for everyone. While these codes have been around, they've been underutilized due to the geographic restrictions. And so we recommend that you stay very close to compliance. As this evolves and changes, we want to make sure that we are current. When we consulted compliance, they made the recommendation that we run all of our Telestroke sites through the Medicare Telehealth Analyzer. This is an analyzer that exists on the HRSA.gov website, and we encourage you to do the same. And what it will do is it will give you the hospitals that you are currently servicing and let you know which ones meet that rural geographic distinction. Now, you may be asking, why do this now if we're removing that restriction? Well, first of all, the sites that meet this geographic distinction will have more flexibility in what you are able to bill because you have been able to bill for these all along. The other thing it will do for you it will help you to analyze some of your claim denials in the future. You may be looking, for example, at two consults that look exactly the same. One was paid and one was denied, and you're trying to analyze why there was a difference. The fact that one of your sites may have met the geographic distinction versus the site that didn't may have been the tipping point. So what we are doing at InTouch with our neurology sites is that we are providing, or we are running each of our hospitals through this analyzer, and we're creating a list of those that meet the geographic restriction and those that do not. Again, we'll be able to bill for all, but it will help us with our analysis afterwards. The second thing we recommend doing in assessing that external environment is looking at your Medicare administrative contractors. They have been awarded the geographic jurisdiction to process the claims, but the other more advantageous in this new field is that they're required to educate providers about Medicare billing requirements. And this is such a new area, again, that we continue to learn, and they continue to delineate the requirements for us. So it'll be really important that we continue to reach out to our regional MACs. We also recommend that you have a process in place to proactively review denials for two reasons. One, it will help you to potentially identify internal process changes to improve your reimbursement rate. And two, it will allow you to provide feedback to the RACs, the recovery audit contractors, whose sole responsibility is to detect and correct past improper payments and make sure that they implement actions to prevent future improper payments. They may also find trends that allow them to make changes within the Medicare requirements so that we can improve the billing process. So as this is new to everybody, it will be very important that we stay close to our MACs and our RACs. The second big component of our planning process was to assess our internal environment. And we really spent a lot of time here. So I'm going to go through each one of these bullets individually and tell you how we used these bullets and how we actually did an assessment of our internal environment. The first part is to define your current scope of telestroke care. You may be a hospital system, and all the hospitals in your system that you provide telestroke care are part of the same system, and you may have access to payer distribution throughout that organization. So for you, you may decide that billing Medicare, Medicaid, and commercial insurance is within your scope. You may be a virtual physician practice that is crossing multiple state lines with numerous commercial insurance plans, and the fact that the plan and the state laws may change may make you have the decision that maybe we want to start with Medicare. Also, when you're looking at the hospital system versus external hospitals, as a hospital system, you may have access to the EMR, which provides you access to consult notes, and it may also provide you access to that patient's payer information, the infamous face sheet. But if you work with external hospitals where you are not accessing their EMR and you do not have access to their face sheet, you would need to come up with a process for obtaining that information from them. And depending on volume, you have to ask yourself if you have a resource to commit to obtaining that face sheet, that information from your external sites. Also, the external hospitals may be looking at their contracts. Many of the Telestroke contracts that were set up for providers were based on a coverage service fee or a per diem fee. And they may be asking themselves questions about how this is going to impact their contract. So how you approach this will depend on the number of hospitals you have within your system and how many external hospitals you're going. And then the last will be the mobile stroke units, and recognizing that you're going to have to obtain that individual patient payer information and what will be your resource for obtaining that if in fact that patient is not presenting at your own hospital. So by defining your current scope of care, it's going to help you determine where you want to start your billing process. The second part of assessing your internal environment is to look at your estimate of the reimbursement based on your current service. And it would seem that it would be easy to say, well, if I did 200 Telestroke consults per month, that would be my billing. But it may not be as simple as that. So in this example, we have a site that does 200 Telestroke consults, with the definition of Telestroke being for the purpose of diagnosis, evaluation, or treatment of symptoms of an acute stroke. However, you may have decided that because you cross state lines and you don't want to be involved in Medicaid state regulations or commercial insurance, you're only going to bill Medicare because you want to meet the regulation requirements. And you estimate that about 70% of those consults are Medicare. That reduces the total of 200 per month to about 140 that you have a potential to bill for. When you look at the 140, you also realize that there are a certain number of interprofessional consultations. Your Telestroke sites are calling you, and they really just have to ask a question. It's more of a provider-to-provider consultation. It is not the telehealth video consultation, and you estimate that about 10% of those fall into that category. So if 90% are actual telehealth video consultations, that brings your total down that are potentially billable to about 126. And then this last bullet has a star in it. Your clinical impression is a stroke-related diagnosis, because we feel that there's a lot of clarity that we still need to learn about this section. For example, when we contacted one of the MAPs and we asked about the impact of the final diagnosis, they stated that the key is that the symptoms have to be of an acute stroke. And if they are present at the time of the telehealth service, we should be allowed to bill, even if the final diagnosis was not stroke. And that we should be sure that the documentation states that the consult was requested for symptoms of an acute stroke. And we were really excited when we heard this. Until the second line was, now if the physician requests a telehealth consult for a patient with Bell's palsy, which is often mistaken for a stroke when a proper neurological exam is not done, then you will be out of luck. So while the final diagnosis does not have to be a stroke diagnosis, exactly what stroke mimics will be covered under this G0 code remains uncertain. And so for that reason, when estimating the number of billable consults that you have, we took a 70% because we wanted to estimate a little bit on the conservative side. So if you estimate that approximately 70% are actually presenting with this stroke and it's not going to fall into this second category, that reduces your total billable consults from the 200 you started to the 88. Besides calculating your potential financial reimbursement and what codes you think may apply to those 88, also consider, do you have the billing and coding resources to now process 90 new claims per month? So these are some things to consider as you estimate your reimbursement based on your current service. The next part of assessing your internal environment is to look at your workflow. And I realize the print on this is very small, and it'll be very individualized. But this is especially important if you are going to be seeking to bill external hospitals when you do not have an EMR access and you need to obtain that demographic face sheet. Are you going to obtain the demographic face sheet on all of the patients? Are you going to stratify the patients based on the previous slide and only collect the information that you need on those patients? Do you have a contact at the Information Management Services Department over in the external hospitals that you'll be able to work with? And again, do you have the resource in your coding and billing to be able to do this as well? So mapping out the process so that it is clear for the stakeholders at your facility or within your provider organization, as well as the external hospital, is going to be very important. When you're assessing the internal environment, you need to look at the telehealth codes, the required documentation, and how they fit into your physician's current workflow. So for example, we looked at the two sets of codes that are most likely to be applied towards an acute teleneurology consult in the ED or inpatient. And those codes fall into the G0425 through 427 and the G0508 through 509. Documentation for the G0425 and 427 will be very similar to documenting an E&M visit, and so therefore need to have the appropriate level of history, exam, and medical decision making. G0508 and 509 were actual codes that came about with the idea of Telestroke, but they have to meet the definition of critical care as well as the time spent on providing critical care. So let's go a little bit more in depth on these codes and the specific documentation. If you look at G0425 through 427, and on the right-hand column, we specify exactly how CMS defines the history, exam, and medical decision-making that is required at each level. One of the questions to ask yourself in your current workflow for your physicians, keeping in mind that Telestroke is an acute, time-based consult that we are trying to achieve a very rapid assessment of the patient for determination of acute therapy. Are they able to do a problem-focused history, problem-focused exam? Are they doing a detailed history, detailed exam? Are they doing a comprehensive history and a comprehensive exam? So when we explore a little bit deeper in these codes and we look at how CMS defines history and exam requirements, we look at the elements required for each type of history: problem-focused, detailed, comprehensive. In a problem-focused history, you need a chief complaint, you need a brief HPI, history of present illness, and that problem-focused history, in order to meet the HPI definition of brief, has to contain 3 of the 8 required elements. You do not need a review of systems, and you do not need the patient, family, or social history. When you look at detailed and you look at a review of systems is required, or you look at comprehensive and you need all the components and it needs to be extensive, it's worth asking yourself if your physicians are able to provide this at the time of their telestroke. Now, if they're becoming the admitting physician, keep in mind that the in-person code will override the distance site code. So if you're only providing the telestroke consultation, what element level will meet, what type of history will meet your current workflow? We looked at the documentation that our physicians often provide, and as an example, a 79-year-old male with a history of hypertension and atrial fib, presents with left-sided weakness and facial droop and a last known well of 12 o'clock. That's a typical statement that starts many Telestroke consults. We realized that it met the requirements for the problem-focused history, but perhaps we were not doing the review of systems or a comprehensive history. Similarly, when we looked at the examination requirements, we had an opportunity to look at a single organ system or a multi-organ system. And when we looked at the single organ system, we realized that the primary examination is the NIH stroke scale, and we may do a little bit more of a neurological exam, particularly if we need to do a differential diagnosis. But again, especially in our simpler consults, we were really meeting problem focused. Moving on to the critical care codes of G0508 and 059, it's most important that the patient meets the criteria defined by CMS for critical care. So in the context of a telestroke patient, the condition acutely impairs one or more vital organs such that there's a high probability of imminent or life-threatening deterioration. Well, central nervous system failure and stroke certainly apply here. The provider's time must solely be directed towards the critically ill patient, and we can certainly say that in that time-based telestroke consult this is true. And high complex decision-making and interventions of high intensity are required, and we know that that's true. So for many of our patients, the G0508 on an initial telestroke consult does seem to fit. The second part of the code is the time-based. And per CPT, a unit of time is reported when the midpoint of the total time within the code description is passed. So for example, in an initial telestroke consult, to report a G0508, 31 minutes, because the midpoint is the total is 60 minutes, 31 minutes would be past the midpoint, must be spent communicating both with the patient and coordinating care with providers. So for many of our patients, the G0508 code may also apply. So making the decision, if we went back to these codes, making the decision between these 5 codes, we looked at it and we said the majority of our patients will fall into a G0425. Those would be our simple exams with a simple history and pretty straightforward, spending approximately 16 minutes on the consult. And for those patients where we are doing an extensive review of the patient who may need recommendations for alteplase, evaluation of advanced imaging, and a review of endovascular eligibility, those patients would fall into the G0508 codes. And that because we rarely do detailed histories or comprehensive examinations, the G0426 and G0427 probably will not apply. This is the type of an evaluation that you're going to want to do so that you can focus on what is going to make most sense for your practice. So moving ahead, the next thing we did was we defined documentation best practice. And to do this, we had one of our coders shadow one of our teleneurologists to determine what we were currently doing and where we may have some gaps in our process. And while I have some of the ones listed here that are common, I'd like to point out a few of them in a little bit more detail. The first one is that reason for a consult. If you recall, that was one of the recommendations that we had discussed earlier by the MAC. So we are going to make sure that code stroke is going to be included in our documentation. If you decide that you're going to be billing for those interprofessional, those provider to provider, those phone consults, do you have a mechanism for documenting those? Per our coding recommendations, we need to have a record of informed consent and a video attestation. And the recommendation was that we had some sort of a statement that said you obtained the patient's informed verbal consent related to the use of telehealth tools. But for some of our patients, they cannot make that verbal consent. And so because of the critical care nature, we want to make sure we can still provide care to those patients. You also want to have a video attestation that says the telehealth tools you used included a live video connection between your location and the patient's location. So thinking about where that may fit into your documentation will be important. And then making sure that you have the critical care time attestation included as well. When we took all of the information into the external and the internal environment, the last thing we never wanted to forget was our physicians and the impact on them. The thing about our physicians is we are asking them to do a very rapid consult on a critically ill patient. Hospitals are really focusing on reducing their door to needle from 60 minutes to 45 minutes. So when this is presented to your teleneurologist, the first statement is, and now you expect me to meet documentation requirements for billing. So it's really important that you develop workflows, you streamline documentation that fits into the current workflow that the physician is doing. One of the things you definitely want to minimize is what we call physician query fatigue. Your coders, billers, your CDISs, which is your clinical documentation improvement specialists, will query the physician if, in fact, documentation does not meet what they expected to bill for. But by streamlining the documentation on the front end, you can actually reduce this physician query. So it'll be important that you engage your physicians. With everything considered, including our physicians' input, we developed a SMART goal. And I highly encourage you use the SMART goal format because there are so many directions that you can go. You want to make sure that your goal will be specific, measurable, achievable, realistic, and timely. It's very easy to get distracted with so much information. So as an example, the InTouch Physician Services made a goal of billing 100% eligible initial acute neurology telehealth. So we weren't going to look at subsequent, and we weren't going to look at interpersonal or interprofessional. Through Medicare and Medicaid, we aren't going to seek commercial insurance beginning in January 2019. I point those characteristics out because it shows how we used our planning process to really limit and define what our goal for billing will be. It is from that that we were able to complete a gap analysis and develop a plan. In our plan, we identified 6 sections: infrastructure, billing process, compliance, documentation, education, training, and communication. These will be unique to each organization. Some questions to consider are related to FTEs, especially if you're seeking external resources, metrics to look at the number of queries to physicians and denials, to compliance, making sure you have state and local regulations, especially if you're going to be billing Medicaid and commercial insurance. Documentation, looking at your documentation compliance, not only at an individual physician level, but to identify process improvements that will help all your physicians in a very short time-based consult. And then never to underscore the value of education and training in your communication plan. Notice we also use the status column where red indicates we haven't started, yellow is in progress, and green is that it's done. And we identify the key person responsible and the target date for completion. and I highly encourage that you do the same. So in closing, if you've noticed, we mentioned multiple stakeholders in this process. We talked about compliance, we talked about information management, billing, coding, physician, CDIS, finance. We believe telemedicine is a critical tool in the evolution of value-driven healthcare. And so for this reason, we took the approach at InTouch that this was more than just being able to drop a bill. We saw it as an opportunity to drive the value of telemedicine into our payment system and demonstrate that we really can achieve the triple aim by reducing costs, improving population health, and improving the patient experience. So for this reason, we hope that when you develop your team, you'll consider all of those stakeholders, you'll obtain the executive commitment, the practitioner engagement, and make sure that your quality professionals are integrated so that you can measure your outcomes and ensure that this is part of your value-driven proposal. Thank you for this opportunity, and so now I'd like to turn it over for questions.
All right, thank you, everybody. So we do have some questions coming in. Just a reminder, if we're not able to get to your question, we will be able to reach out with you via email after the end of this webinar. So to start things off, the first one is, will InTouch be providing resources to upgrade our stroke response template? And similarly, what technologies can be used for payment of telestroke services?
So I'll take the first part of that. Yes, we are. We are currently, from the template in the stroke response template, we are currently testing and piloting that with our physician services, and we will be providing additional information to our customers in the near future. Jordana, did you want to cover the technology?
Sure. When it comes to the technology, in order to get paid for Telestroke, you will need to use an interactive audio-video telecommunication system. That is a requirement or condition of payment for Telestroke.
Okay, great. Another questions that are coming in, detail around the G0509 code for the critical care code, since you spoke about the G0508 code.
G0406, 407, 408, and 508 are all considered follow-up or subsequent codes. So when we focused on our billing, we looked at that initial consultation. G509, while it is a critical care code and you have to meet the critical care requirements, the main difference between 508 and 509 is that on the initial, there is a 60 minutes, and on the subsequent, there is 50 minutes. But keep in mind that you can only bill one code for a patient per 24 hours. So, for example, if you see a patient and then you're called back later in the same 24-hour period, the G0508 code would still apply. G509 would not apply until after that first 24 hours, and then you would be able to bill for the subsequent code.
Okay, great. I believe this one could be answered by you, Jordana. Can CMS remove the rural requirement for other telehealth use cases beyond Telestroke?
Well, that's a good question, and I certainly wish it could happen that way, but unfortunately, only Congress can do this. Only Congress can remove the rural restriction because that is the specific language that we have in the bill. So unfortunately, CMS has to work within the language of the statute and can't address that directly.
Okay, great. And then I think we got time for one last one, which is around if anyone is looking for resources on these new payment rules, including where to go for more information and what can be approved for coverage at the state level. Is there any locations they can be looking at?
Shelley, I can take this one. Yes, there are some really wonderful resources that are available. First, you can download several of these resources here in our webinar widget just by clicking on the resources widget, and in there you'll find the 2019 Physician Fee Schedule's final rules. You'll see the Medicare Learning Network's fact sheet for the new Telestroke modifier. And we've also put together a summary of all of the reimbursement changes and opportunities coming out of the Physician Fee Schedule for you as one of those resources. And then for statewide information, one of the best places to go is the Center for Connected Health Policy's website. This is the National Telehealth Resource Center for Policy, and you can find them at www.cchpca.org. And on their website, you'll find a wealth of information around state-level telehealth, including their biannual report on state telehealth laws and Medicaid reimbursement policies that comes out twice a year.
Okay, great, thanks. And then I think we have one short one we can get to right now. So the question is, so telestroke evaluation that lasted 14 minutes would not be reimbursable?
And I can take that question. Yes, it is reimbursable. It may not meet the requirements for the critical care initial consult. Remember, the critical care G0508 states that you have to pass the midway point, and that midway point for the G0508 would be a 31 minutes. In terms of 14 minutes, if you're looking at G0425, that's an E&M code. And so that E&M code is looking more at the documentation and making sure that your documentation meets the minimum. So when you're looking at the 0425 to 0427, you're looking at documentation requirements. When you're looking at G0508 and G0509, you're looking at critical care billing time.
Okay, awesome, thank you. So we're running out of time right now, so I'd like to give a big thank you to Jordana and Shelley for today's presentation. For any additional questions or information, please contact us at feedback@intouchhealth.com, or you can contact us directly at the email address on the screen now. And then also, please visit our website to find other on-demand webinars that you may be able to view at your convenience. And this concludes today's webinar. I want to thank you all for giving us your time, and have a great day today.